Good morning. Thank you very much for the opportunity to be here. It's really exciting to see, how this meeting is growing from strength to strength every year. So these are my disclosures, and this is a really nice segue for what I want to discuss, which is catheter-based treatment options for PE, not in vein anymore. So I'll start with a case, some of which has already been discussed, but this is kind of a typical case that a PERT team, for example, might encounter. A 60-year-old woman with progressive shortness of breath, lightheadedness, goes to see her PCP, is diagnosed with pneumonia, started on antibiotics, has kind of the usual litany of chronic conditions, including hypertension, thyroid. She did have a recent lower GI bleed and does have a history of COPD and arthritis. So this is, after a couple of days, the symptoms got progressively worse and she showed up in the ER. At that time, on presentation, her blood pressure was 90 systolic. This is her EKG. In addition to the fact that she's tachycardic, she also has a classic S1Q3T3 phenotype on the ECG that we see not infrequently with patients with large PEs. The troponin was also elevated. She underwent an emergent CTA for presumptive diagnosis of PE, and as you can see, she has an extensive clot burden. She has a clot that is visualized here both in the left as well as the right, and the burden on the right side was significantly greater, and it extended all the way from the right PA into the secondary and tertiary branches as well. On echo, she had evidence of significant dilation of the RV, and you can see that the RV is compressing and pushing the septum over towards the LV, and there's the D shape of the septum that you can visualize there as well. So she was referred for angiography and potential embolectomy. So first, we crossed, and then this is the angiogram initially. We did angiojet with pulse spray thrombectomy, a little bit of balloon dilatation as well, and this was kind of the final result we had with the catheters, and then we left the EKOS catheters in from the neck, and this is typically 1 to 2 milligrams an hour for about 12 hours. So then she had a repeat CT at 3 days, and you can see over here that most of the clot burden has resolved. There's still some residual thrombus in the left, but significantly better than what it was before. And on the right side as well, the main PA has significantly cleared up, and she just has some more in the distal vessels. So this is also what her echo looks like, and you can see the RV still looks a little dilated, but significantly better than what it did when she presented to the hospital. So again, this has been discussed, but annually it is estimated that there are 4 million surgical patients and 8 million so-called medical patients who are admitted with a number of different medical conditions that are at least at moderate to severe risk of pulmonary embolism. 42% of medical patients and 64% of surgical patients who are admitted can be considered to have this. The risk factors are, previous thromboembolic disease, bed rest, the presence of catheters, as well as cancer. And, as has also been discussed, it would be wrong, just like not all acute coronary syndromes are the same, it would be wrong to think about pulmonary embolism as one disease. Rather, there's a wide spectrum of clinical manifestations. On the one side, a little more than half of these are subsegmental. These are hemodynamically well-tolerated PEs, and probably the vast majority of them are best treated with anticoagulation. On the other side are the ones that are most feared, probably about 4 to 5% of all PEs. These are the massive PEs that present with severe RV failure, hemodynamic or electrical instability, blood pressure is less than 90, syncope, and usually cardiac arrest. The 90-day mortality is extremely high, more than 58%, and traditionally these are the patients that have been treated with systemic lytics. So about 30 to 50% are patients who present with what is now called intermediate risk or submassive PEs. These are patients who have evidence of RV strain, but they do not have obvious hemodynamic compromise. They do, however, have increased mortality, and it is estimated that about 10% of these submassive PEs then go on to progress to massive PEs. The 90-day mortality for this is also actually very high. It's about estimated 21%. And the biggest sign of a submassive PE is RV dysfunction, whether that's based on CT or echo. You have an RV to LV ratio of greater than 0.9. You have elevation of either BNP, troponin, NT-proBNP. You have EKG changes. These are all signs that this patient is likely having a submassive PE if they don't have hemodynamic embarrassment. So the treatment options are typically anticoagulation with some form of heparin or fondaparinux, systemic lytics, which again has traditionally been reserved for patients with massive PEs, catheter-directed thrombolytics, mechanical and pharmacomechanical interventions such as angiojet that I discussed earlier, and of course, surgical embolectomy. So we looked at the role of lytics in PE. This was in JAMA a couple of years ago, and what we found is that the mortality with thrombolytic therapy compared with anticoagulation is better with, this is in all comers with both intermediate risk as well as high risk PE. It was definitely better with lytics versus just anticoagulation. However, the risk of major bleeding was 1 in 10 and a number needed to harm of 18 patients. So when you look at this, it's heavily age dependent. So when you look at patients older than 65, they clearly have a very low number needed to harm. And so older patients presenting with massive PEs, even though there's a preserve or a trend towards mortality benefit, you would end up harming a lot more than you would help. Younger patients, on the other hand, the number needed to harm is 176, so suggests that age could be an important discriminant for this. When we looked at intermediate risk PE patients, again, we saw that the mortality did end up being lower in lytic patients, and the number needed to harm was also 18. So this is also a group that systemic lytics, about 8%, slightly lower, but not significantly lower than patients with massive PEs. So catheter embolectomy procedures, there are many ways of doing this, and there's kind of no right way. It really depends on the thrombus burden and the extent of involvement. There are techniques involving thrombus extraction, maceration, fragmentation. There is lytic therapy, typically rheolytic therapy with angiojet. Balloon angioplasty can also be helpful. In the case I showed, we did end up using a few balloons just to improve distal patency. As Dr. Mahmood will talk next, I think this is important, increasingly becoming a treatment option for chronic thromboembolic disease. Pulmonary artery stenting is sometimes required. And then these indwelling catheters are typically very helpful in these patients. And so, you can use just a small infusion catheter and leave that in, and that kind of drips in TPA. The dose that you would give would be significantly lower than what you would give with systemic lytics. Of late, there's been a lot of interest in EKOS, and I know this was discussed also for the DVT section, but this is just a quick overview of the EKOS catheter. This is an infusion catheter, but also has an ultrasonic core. And so this is porous, and so it allows for the diffusion of TPA directly into the clot. But by having the ultrasonic core, it allows for a greater penetration of the lytic into the clot. And so if you look, there have been 3 trials done with the EKOS catheter. The first was the Ultima trial. This was in circulation in 2014. And this was a small trial, 59 patients. They compared EKOS catheter to just unfractionated heparin in patients with submassive PE. And the primary endpoint was RV systolic dysfunction. And you can see at 24 hours and then subsequently at 90 days, there was significant improvement in RV dysfunction in patients who got EKOS-guided catheter-directed therapy versus patients who got unfractionated heparin and anticoagulation alone. This was then followed by the Seattle 2 trial. Now, this was a single-arm trial, and it really was trying to see not just RV dysfunction, but whether you could actually change this RV to LV ratio, which, again, a ratio greater than 0.9 portends a really poor outcome. And so this was a single-arm study. There was no comparison arm, but it was done at 22 sites, and what they found is by using the EKOS catheter, you were able to significantly reduce that ratio. And then finally, the Optalis PE trial was just presented a couple of months ago at the ATS meeting in DC. Now, this was interesting. Typically, with the EKOS catheters or with any of the infusion catheters, you give a milligram or so an hour. With the EKOS, we typically use about 8 to 12 hours of TPA, and with the simple infusion catheters, it ends up being a little longer. So what they sought to see is, since a lot of the bleeding is obviously going to be driven by how much TPA you're infusing, if you compared kind of a standard 6 hours is actually probably a little bit lower than usual even, but a standard TPA infusion through the EKOS catheter with different iterations of using either a lesser dose or shorter duration. So at the extreme was just a 2-hour EKOS infusion with 4 to 8 milligrams of TPA, which is nearly a tenth of what you would use systemically for lysis. And what they found actually is that although there was no direct comparison between the arms, it was a 101 patient study, 17 centers. It showed that in all 4 arms, the change in the LV-RV ratio was actually pretty similar. So if you look at the bleeding profiles, in this trial that I just described, the EKOS, the TPA was only infused for 2 to 6 hours. They used a significantly lower dose of TPA, and the reduction in RV to LV was actually pretty similar, about 25%, and they had only 3 bleeds, so about 3%, and only 1 intracranial hemorrhage. The Ultima trial, which I showed earlier, was a much smaller trial, and they had 0 intracranial hemorrhage and major bleedings. Seattle 2 had a more generous definition of major bleeding, and there they had nearly a 10% risk of major bleeding. So bleeding profile, if you remember, with lytics is about 10%. 1 in 10 will have significant major bleed. With EKOS, it looks like if Seattle 2, again, I think they were the definitions were a little bit different, but it looks like with the EKOS catheter, the bleeding profile may also get better. So what do the guidelines state for catheter-directed therapies for PE? This is the AHA scientific statement from 2011. For massive PE, it is a class 2A to use catheter embolectomy and fragmentation or even surgical embolectomy if contraindications to lytics is reasonable. And for submassive PE, now again, a lot of this data has emerged in the last few years, but if there is evidence of severe RV dysfunction, major myocardial necrosis, or worsening respiratory insufficiency, it can be considered as a class 2B. So, it is certainly time to update these recommendations, and in fact, there is the AHA is convening another group to revisit this statement, specifically looking at interventional therapies. Jay Geary from Penn is the chair of this, and I'm one of the members of this, and will be evaluating a lot of these devices and therapies to see, what the efficacy of these and safety of these devices may be. So in conclusion, patients with intermediate risk PE or submassive PE have RV dysfunction and have very high mortality and morbidity. In these patients, anticoagulation alone appears to be inadequate. Systemic lytics do carry a high risk of major and or life-threatening bleeding. Catheter-directed approaches have demonstrated promising efficacy with relatively low major bleeding event rates, but before they can be routinely recommended in all patients presenting with PE, larger trials are needed to assess the efficacy better. Thank you very much.